Our next speaker is Dr. Matt Surratt, a medical oncologist at Diablo Valley Oncology.
Hi everybody. I too want to thank you all for coming to our gathering on prostate cancer. I've been at Diablo Valley Oncology for 25 years. I've been in oncology for 25 years. I've only been at DVO for about 22 of them. So way longer than Sophia, but not nearly as long as Dr. Taylor. So I want to talk to you about a couple different things. The role of medical oncology, what do I have to do with all of this? And also I'm specifically going to focus on some of the newer data that's out for medical oncology. So in early stage disease, when the urologists and the radiation oncologists are fighting over who should treat the patient, one of the things that the medical oncologist does is helps in decision-making process. So I'll often see patients who are confused. Should I do brachytherapy? Should I watch and wait? Should I have a prostatectomy? And I'll help them work through those issues. I don't actually do any of these treatments for early stage disease, with the one exception of sometimes patients get a hormonal therapy, which is an injection, with their main treatment. Usually it's with radiation therapy. It's usually temporary. It ranges from 3 to 36 months of treatment, depends on how high risk the patient is, and we'll often administer that. And I also follow some patients along when they've been treated and then they need follow-up care. More importantly, my role is to treat them when it's a late stage cancer. What is a late stage cancer? Generally, it's at least after the patient has positive nodes. That's usually where the first point at which I'll be involved. More often is when it's even the lymph nodes are more the disease is more advanced. And for instance, it's spread to the bones, which by the way is the most common place that prostate cancer spreads when it's not regional, by like 90%. It really almost always goes to the bones. There are some patients who it goes to the lung earlier on, but usually it's a problem in the bones. And then I also help with supportive care for whatever is necessary, whether it's pain control or anything like that. So a lot of times you don't trust the guy with the big finger, and that's when the medical oncologist comes along and says, yes, Dr. Taylor really should be the one who operates on your prostate cancer. Or sometimes I say, you've had 3 heart attacks and a stroke, maybe an operation isn't the right idea for you. We do hormone therapy for prostate cancer. Prostate cancer feeds off of testosterone. If you remove testosterone, most patients will respond, the cancer will shrink. In Europe, hormone therapy alone was the standard of care for prostate cancer. They didn't do radiation almost ever, and they rarely did prostatectomy relative to us. They would treat their patients with just hormone therapy, mainly because it's rather inexpensive. There has been a study that looked at that, and what they did in Europe was they looked at hormone therapy with or without radiation in this case. In this country, we've tended to run studies the other way, where everybody gets radiation and some people get hormones and see if it helps. Turns out the survival advantage at 10 years was quite significant. This is overall survival. So an overall survival increase by half, 40 to 60%, is very significant. They didn't see on this particular study a lot of heart toxicity, which is one of the things we worry about when we manipulate hormones. This is the definitive trial. This trial really increased the amount of radiation therapy that is now being performed in Europe. Europe is less surgically oriented in general than America. America, our big cancer hospitals, particularly Sloan Kettering and MD Anderson, they began by surgeons as surgical hospitals. That's how the treatment began, and so many of us have more of a bent towards surgery. I do want to comment, let me just go back for a minute. Last line there, 70 gray of radiation in this trial. We actually do more. We go to a higher dose at our center. 76, Sophia? 78? 79.2. So we believe that there's a dose response. If you can give more, you're more likely to cure the patient, which just makes sense. Medical therapy, what I do is utilize when the disease is more advanced. And usually in prostate cancer, that is hormonal therapy. Hormone therapy means in some way you turn off the testis. It can be done surgically. You can have a surgical castration. Not a popular operation, generally emotionally difficult for men to accept, and not done all that commonly anymore because we have easy ways to do it medically. And two, there's been a theory that intermittently giving hormones and taking them away may be better, and people didn't want to go through and give testosterone after they've done the castration. That had not been studied. So usually hormonal therapy is administered via a shot. Prevents testosterone production. It's got a known side effect profile, and it'll control the disease in some patients for 5 to 10 years, even with bone metastasis. On average, it's more like 2 to 3 years. That's the way the standard has always been. There are some newer hormonal agents. The newest one is daguerreotyx. One of the differences with our older hormone, there are many of the older ones, is that the PSA drops abruptly and immediately. So you go from your PSA of 50 to 0 in 2 or 3 days. It's very, very quick. And there is some data, this is new, so we don't have a lot of data, that PSA control rates are improved. Bone enzymes remain normal or normalized faster with this. There was a meta-analysis where they take a whole bunch of other studies and lump it into one. There's some statistical problems with doing it, but it is something we do a lot. They saw an improvement in the time that it takes for the disease to come back, or progression-free survival. It's a monthly injection for somewhere between 3 and 12 months. I'd use it for 12 months. And then you switch to the shot that lasts longer. Downside is we don't have longer experience, so I'm not positive that people will live longer by this. It's a monthly shot, which is more difficult than some of the other mechanisms that we use. However, many of the patients are coming in monthly anyway for something else that we do for the bones once a month, so it's not that big a deal to get a second shot. Daguerreotyx is more expensive than the older drugs. What else is new in medicine? After removing testosterone, there's still possibility when the patient starts to progress. What happens? The cancers are smart, just like bacteria. Bacteria become resistant to antibiotics. So nobody gets penicillin anymore when they get an infection because penicillin doesn't treat any of the bugs anymore. They're all resistant to it. Well, cancer is smart, and it becomes resistant to testosterone removal. How does it do that? It's a very complex mechanisms that allow it, but there are pathways that become enacted that allow the cancer, whereas before it needed testosterone from outside to grow. That's what stimulated it. It doesn't need that. Some of the newer treatments, abiraterone and enzalutamide, and there'll be a test for me too, you have to be able to pronounce them, work even on hormonal production even after the patient is castrated and doesn't have exogenous or outside testosterone. How does it do that? One of the coolest things that the cancer cells do is they begin to produce their own testosterone and then use it to grow, which is smart on a cancer cell. This blocks that production too. So it blocks production at the tumor and also blocks a little bit that's made in the adrenal. This drug by itself increases survival 4 to 5 months. Now, I'll talk to you in a minute about what that means. It's usually after hormone failure. That's that first treatment I talked to you about. But now there's something we do before this that's very new, which I'm going to talk about next. When I mention increased survivals measured in months, you have to understand that's a median survival. It does not say what one person will do. It does not mean that if you get this treatment, you will live 4 months longer. It is not what it means. Moving a median is very hard in cancer medicine. You can make 49% of the people cured, and you won't move the median if that's the exact number that you hit. You have to improve more than half of them to move a median. So we can take patients and cure 10% of them when they were all not going to be cured, and it still might not move the median. So it is difficult to move a median. So when we start seeing, in oncology, medians that move 2 months, that drug will get approved by the FDA. When we see 4 to 5 months, or certainly more, we're happier with that response. So that's where this 4 to 5 months comes from. What just came out this year at a plenary session at ASCO, which was in June, was combining chemotherapy with hormone therapy up front. Taxotere is the standard of care when hormone therapy stops working. It is a typical chemotherapy. It is a drug that kills cancer cells. This one happens to work by preventing the cells from dividing into two. It affects the structural system that's there. We've always used it after hormones. When you use it after hormones, people live about 3 months longer. There's a 50% increase in the 3-year survival. Some patients respond a long time. My longest is 4 years. I've had one patient who continued to respond on and off to Taxotere for 4 years. It often makes people palliated. Their bone pains go away. Their energy gets better, something along those lines. This was the standard of care. Hormonal therapy, abiraterone, second line hormonal therapy, and then chemotherapy. And then the CHARTED trial was presented at ASCO this year. This puts Taxotere up front with hormonal therapy. This was a very large trial in prostate cancer, 800 men. And there was a huge, unexpected, and striking survival advantage of 1.5 years. I don't know that I do anything else in my business other than the patients that are cured that extends median survival by 18 months, especially in prostate cancer, which is a solid tumor, often in older folks. This was presented and is immediately practice changing. So we no longer, assuming you're a candidate for Taxotere, should no longer be talking to patients just about hormone therapy. It should be hormone therapy with Taxotere. This has probably been the most talked about abstract that came out at ASCO. It's been in all the newspapers. It's a big deal. So now, the patient shows up to me with metastatic disease, and they're a good candidate. Metastatic means it spreads. So a patient shows up with bone mets. They present with prostate cancer, and it's already far advanced and into their bones. They will no longer get hormone therapy, which will work a median of 2 or 3 years. They will get this therapy, and they will do much better. There are also other newer agents that are out over the last few years. The one that made a big splash because the stock took off from the company that makes it is called Provenge. This is the first treatment vaccine in the history of cancer. We have a lot of vaccines in medicine, but this is the first one that's used to treat an active cancer. The HPV vaccine, for instance, for young girls, prevents cervix cancer. It doesn't treat it. By the way, it also prevents certain head and neck cancers now. Anyway, Provenge is fairly easy to administer to the patient. It doesn't have the toxicities that chemotherapy does. 3 treatments, you sit in the chemo suite, it takes a half an hour to go in. It doesn't have a whole lot of side effects. Again, it prolongs survival, in addition to the others, by about 4.5 months. It tripled the 3-year survival. There's some disadvantages. It has no PSA response. It's the only treatment that I do where I don't see the PSA go down. We don't exactly know why that is and why people are living longer. We know it's an immunologic mechanism. Provenge, what we actually do is we use the pheresis, which is a procedure where we take out your blood, we spin it down, give you back your blood cells, take the plasma, send it to a lab. They grow it up in the presence of an immune stimulant and send us the product back. So in that respect, it's complicated. It's not complicated for the patient. It's complicated for the office, and we have to time this stuff very perfectly. So you have to have pheresis available. You can't get this in the middle of nowhere in Iowa or Kentucky. We do it here because we have the blood centers that can do the pheresis. It's expensive. It's $93,000 a course. That's just for the treatment product itself. I'm not going to spend any time on this one. Jevtana is a chemotherapy that came out after Taxotere. It's very similar to Taxotere, has a 2.5-month survival advantage. It is the only FDA-approved treatment for chemotherapy for prostate cancer. It's expensive, but less than Provenge. It is a typical chemotherapy with the usual side effects and problems that chemotherapy has. Xofigo came out a year ago. It is an alpha particle emitting radiopharmaceutical. So basically it's an injectable radiation. It's a very high energy beam and it travels a very short distance. And it works for bone mets, only for bone mets. Another name for it is radium-233, same radium that Madame Curie used. What happens, we inject this product that goes into the bone, and whatever cancer cells are in the bone get radiated. We've had drugs like this for a long time. Rhenium and strontium have been available for decades. This is the first one that works well enough that it caused a survival advantage in its studies of almost 4 months. It can be given at any point during the treatment. Besides making you live longer, it prevents skeletal events, fractures, need for palliative radiation therapy because of pain, compression fractures, things like that. I write minimal side effects. That's what's reported. I'll be honest with you, we don't have very many patients who've gotten it yet. It's so new, it came out this year. The data reports improved quality of life. It's an injection once a month for 6 times. We tend to reserve it for patients who are having symptoms from their bone mets rather than just having them. So we just, you know, you might be on observation for a while before we actually do the Xofigo. So one of the questions that always comes up is how do you decide on which treatment for who? You talk to the surgeons, you talk to the radiation oncologists. You have to think about your own medical history, and so should the doctor. The doctor has to think about your medical history. These agents, for instance, someone with low blood counts as a baseline, which is a patient that I'm seeing now, Xofigo is not exciting because it radiates all of the bone marrow. So the patient with low blood counts is likely to run into problems with very low blood counts, which is what is one of the main reported side effects of that treatment. Other patients who have bad heart disease, hormone therapy can be a problem with bad heart disease. When we used to give people steroids, which also works, we increased the number of heart attacks. Now that's very old data. We're still studying who should not have hormonal therapy. And in general, it's pretty safe. But someone who just had a heart attack, I would probably not be excited about hormonal therapy, especially if it were just as an adjunct. With prostate cancer, there's almost always time for second opinions. The exception would be if there were an emergency like a fracture. If you present with a spine fracture that needs urgent radiation, yeah, you got to get that treated right away. But for the most part, as Dr. Taylor mentioned, it tends to be sort of a more slow-growing disease. So even with a high-grade prostate cancer, a Gleason grade of 9, that's a prostate cancer you want to treat. Doesn't necessarily mean you need to be treated today. If you had your trip planned next week for your 30th wedding anniversary, you can go on your trip and then get your treatment after that. So you do have time for second opinions if that's what people feel they need. I give a lot of them at the early stage. And I also usually talk to the primary care physician who knows the past medical history. Some of our patients are older. They're not in their 60s or 70s, they're in their 80s. And those patients, we have to decide, do we even want to treat them? Many patients in their 80s, shouldn't have PSAs checked anyway, and probably don't need treatment because the prostate cancer is not going to bother them in their lifetime. But there are some 80-year-olds who are young and vibrant and have a Gleason grade 10 prostate cancer that's in the seminal vesicles on an MRI. That patient should probably be treated because maybe he was going to live to be 95, and you do not want to have advanced prostate cancer if you can help it. It's a rather morbid condition. And that is all of my slides. Thank you very much for your attention.